Yes. Good afternoon, everyone. I think we'll get started here. There is a sign-in sheet going around. I'd like to welcome everybody to coalition bargaining for calendar year 2024. I'm Tim Kubrick, Director of Labor Relations, and I think we should get started since we do have some new faces here. Get started with some introductions. So. Use your microphone because the video can't.
Jean Marie Middleton, Office of General Counsel.
Jermaine English, Manager, Labor Relations.
Heather Frederick, Chief Financial Officer.
Nancy Bolton, Director, Risk and Benefits Management.
Marilyn Busico, Benefits Manager.
Carol Sessions, School Police, PBA.
Officer Lepore, Palm Beach County PBA, School Police.
Pat Kalps, Palm Beach County Staff Association.
Gordon Longhofer, CTA Vice President and President-elect.
Justin Katz, CTA President.
Theo Harris, CTA Executive Director.
Jesse Brown, President of ASAP.
Joseph Brenner, SEI.
All right. Thank you all for being here today. So, opening up bargaining for calendar year 2024 benefits. We have scheduled 5 sessions beginning with today, one for each of the next 5 months, just to reserve some time to make sure we have enough time to review the plans that we offer, discuss changes for the calendar year 2024. During last year's negotiations, we touched a little bit on the potential need for some increases, but we were able to avoid that with some minor plan changes, also some hefty contributions of ESSER funds. But after after avoiding these increases for a decade now, we don't have the same flexibility we've had. So we do have a presentation that Nancy and Heather are going to go through and walk us through a more in-depth view of what's happening, and then also some recommendations that we could then discuss. So we'll get started.
So we're going to start off with a legislative update. There's been a lot happening in Tallahassee, so I'm going to that are going to have a pretty significant financial impact to the district. So I'm going to start with that. Then I'm going to pass over the good news over to Ms. Bolton, so she can go through it. Just an overview of the plans that we offer, the monthly claim trends that we've been sending out every single month and that we've been reviewing each quarter, going through where we stand with those claim trends. And then going into our funding history, we have been very fortunate. Mr. Kubrick mentioned that we haven't had an increase in 10 years in health premiums. And really where our issue stemmed, where our expenses started to exceed our premiums was a result of COVID. We had a pretty significant hike in premiums as a result of COVID going in from 20 to 21, 8% increase. Our increases in our health claims have always been significantly below the national trend. During COVID, we're actually at the national trend for the first time. We were able to utilize and have been utilizing ESSER funds. We plan to invest $45 million of ESSER funds into the health plan, which has helped offset that deficit that we've been seeing between the premiums we're collecting and the claims that are being charged. But now we're ESSER funds are sunsetting come June 30th of 2024. So we have to have a plan to make up that shortfall. The actuary recommended an increase last year. We weren't ready to actually pass that increase on to the district or to employees. We wanted to wait and see where claims actually settled because we did have that significant spike. I did anticipate having a decrease. I knew we weren't going to go back to pre-COVID levels, but did anticipate that we would have fallen more than what we have. So we did fare better than what the actuary had projected. The actuary projected a 2% increase in claims, and when Ms. Bolton gets to the monthly claim trends, you'll see that we actually had a decrease of 1.5%. So that's a spread of 3.5%. Actuaries are notorious that they're overly conservative. So we want to show a comparison between where we stand with district, based on district past trends, and then compare that to the actuary, and really, hope for that best case scenario, and then monitor on an ongoing basis to see whether we're going to need any future increases. So with that, I am going to, and then also wanted to get into comparing where our premiums are for our district compared to other school districts, because we do fare better, and the district does heavily subsidize the health premiums, especially when you look at dependents. And so when we look at our proposed changes and recommendations and next steps, looking at, because we're not going to come to you today. I don't want you to expect that we're coming to you to say that this is the increase we're proposing and this is what the impact would be to the premiums. So this is just walking through to say where we're at right now, and then in our next meeting, that's when we expect to come with proposed changes to the premiums. Getting into the legislative update, House Bill 1 has been signed and passed and then signed by the governor. It expands the voucher program and eliminates pretty much all the eligibility requirements other than being a K-12 student. There are still some caps. We expect to be some caps based on the growth. So if there are more requests for vouchers than are available based on the growth caps that have been established, the priority will be given to those families that are up to 400% of the federal poverty level. But if there are requests for vouchers and they don't exceed the caps that have been set aside, there is no income eligibility requirement any longer. So we do anticipate to see a pretty significant growth in the vouchers this upcoming year. We're at about a little over 11,000 vouchers in Palm Beach County. The Senate budget is proposing that the number of voucher students will increase to 17,500 in Palm Beach County. The Senate budget is setting aside a reserve of $350 million, and if more voucher students apply than what's anticipated, they have a reserve of $350 million. The House budget, though, is only setting aside $100 million. In addition to that, the House and the Senate have just fundamental differences in how they're showing and representing the budgets. The Senate's is pretty consistent with how we've seen it in the past, which is they're keeping all the categoricals. They're actually breaking out the family empowerment scholarships into a separate line item. So instead of them being included within the district FTE, which is how they're handled right now, just like charter schools, the Senate is proposing taking them out. And by doing that, it's setting aside a fixed budget for the vouchers. And that way, if the vouchers end up coming in higher than what's anticipated, that difference won't come out of the district budgets. The House, though, is proposing a complete fundamental change to FEFP. They're taking several of the categoricals that are set aside for instructional materials. I believe the one for mental health. I think I have them listed in here. But for the board presentation tomorrow, I do have them spelled out. They're taking those categoricals and they're folding them into the base student allocation. So what that's doing is it looks like the base student allocation is increasing by a very significant amount, but then you would look at, there's going to be a corresponding decrease within the categoricals, because all they're doing is moving them from the categoricals up into the base student allocation. And then what is in the House Education Conforming Bill is that the districts still need to comply and spend the instructional materials on instructional materials, and they still need to spend the mental health on mental health, but then they're folding it into the base student allocation. So they're giving us the state mandate to comply, but they're not leaving it as a separate categorical. The other significant difference between, and this is the most significant difference between the Senate and the House proposals, is the House is estimating 40,000 less voucher students than the Senate proposal. So their funding is basically the same. It's not much different, but yet the House budget is built on 40,000 less students, and then also $250 million less in reserve. So if we were to look at the House budget right now, and I normally would show a whole very detailed line item of each of the categoricals down to what the expected dollar amount is for Palm Beach County. But because of the differences in the presentation, I'm not even able to do that at this point. So if you were to take the House Education FEFP proposal and take into consideration the shortfall in students they have, our district would end up with a negative, potentially $50 million in revenue. So a negative, like an actual cut in revenue. So the House and Senate budget bills are so far apart at this point that we're going to have to wait until the conference is complete to see where we end up. That's just with the budget proposals. So then it gets a little bit worse. So we still have sovereign immunity. So sovereign immunity, as a district, as a governmental agency, our sovereign immunity is capped. So right now it's at 300,000. Last year there was a proposal to increase sovereign immunity and what those limits are in terms of our liability if there's a case that's brought forward. And it didn't pass last year. It kind of died during the session. It was initially, sovereign immunity increase was initially, at the start of the session, there was no limit that was established. They just wanted to eliminate sovereign immunity for governmental agencies. The House then came back, and instead of having no limit, they came with a $2.5 million. And the Senate's current proposal is 400, 600, which is double what our current liability limits are. So our district is self-insured, and so this could, depending on what happens, could have a significant financial impact to the district. There was one positive. We have the class size bill, and right now, the proposal is to eliminate the financial penalty for noncompliance. Districts still need to comply, and they still need to say how they're going to comply, but it eliminates the financial penalty for complying with class size. Another bill that was a positive bill that passed is tort reform. So there was significant changes within this bill, that there were, I think, over 20,000 cases that were filed right before this was passed, so that the trial attorneys were able to get them in before the law changed. So we don't know how long all of everything that was in here is actually going to stay in place, but this does have a positive impact on the district. Going into, when we're looking at health benefits as well as FRS benefits, however much money we have to pay, that just takes away the available money that we have for raises. So if the district puts in $20 million into health benefits, that's equivalent to almost a 2% increase, because it costs $12 million for each 1% raise that's given. So when you're looking at, not only considering the increase in health benefits, we're looking at an increase in the FRS rate. So we have two bills. We have House Bill 239 and Senate Bill 7024. The Senate bill, I'll start with that one, is just status quo, keeping everything within FRS the same, and just funding that unfunded actuarial liability. There's been about, we've been pretty consistent seeing 0.7 to 1% increase over the past several years because there's been a change in the discount rate that was used. And so we'd have to help fund what that new shortfall is. And so the state has been phasing that in. So the Senate is just keeping that status quo. They're proposing a 0.7% increase, which for our district is equivalent to $7 million. The House, on the other hand, has pretty significant changes within their bill, which cost is estimated to be an increase of 5.7%, which is equivalent to $57 million. The most significant change that the House is proposing is adding back those cost of living increases that were taken away pre or post 2011. As CFO, I'm not supportive of House Bill 239. I don't believe it's sustainable. It's expensive. I don't know how we would fund it. It would take away pretty much whatever funding we do get, and then some, at a cost of $57 million. As a participant in the pension plan, I think it's amazing that we might get our cost of living back, so kind of torn, but as CFO, I have to say, it's not something, that we're supportive of. So in addition to the cost of living, there's a lot of changes to the special risk areas, adding back some of what was taken away post-2011. So the reason why I went over this is to say we are facing a very tough budget cycle, just as we have in past years, and now even more so because of the looming ESSER funding cliff that's coming June 30th of 2024, the expansion of vouchers, what that is going to actually look like for our district, how it's going to impact us. Because what vouchers is doing, it's not, for the most part, our district does not have declining enrollment like other districts south of us have had. What it's doing is just adding additional students into the public education funding that never, ever would have gone to public schools to begin with. And so it's not necessarily taking those students away, but just adding them and inflating the pool, which is then going to reduce the amount of, potentially, if the state doesn't continue to fund it, reduce the amount of money that we receive. In addition to that, we are going to have increased competition, and we do concede that that is something that we need to do. Competition isn't bad, but we do have to make sure to compete with these students and show them what programs and services we do offer. So with that, Ms. Bolton is going to get into some more of the details.
Okay, so this will be mostly just sort of, if you will, an illustrative reiteration of what Heather opened with. But just starting with an overview of the health insurance and benefits offered to our employees. We offer, of course, our comprehensive insurance through United Healthcare, our high HMO, low HMO, and consumer-driven health plan options. That will be the main topic of our discussions today because that is our cost-driving benefit. Our dental insurance, voluntary program with Humana, we offer those plans, 4 different versions of that, a vision plan. Also our disability income protection, long and short-term disability, term life and accidental death and disability, and our employee assistance program. We don't anticipate any dramatic changes in those benefits. In fact, currently we don't anticipate changes for plan year 2024 at all in those plans. So our conversation will focus on our health insurance plan. So the claims expense by month, we've just put this here for you because it should look somewhat familiar to you as we send it along each month. It illustrates claims and pharmacy claims incurred. It's just raw claims data. It doesn't include administrative costs or other cost factors. The spreadsheet that we send to you all does include the benefit of our pharmacy rebates that we receive every quarter, and that reduces the ultimate spend in pharmacy. But it's just kind of a good real-time snapshot every month to kind of look at how our claims are trending over the year. You'll notice that January was phenomenal. I mean, I was so optimistic when January came in, but then February came along and was not. Our shortest month of the year was particularly high, and that was both pharmaceutical and medical claims, jumped about 500,000 each, roughly, and totaled 20 million. And so the combination of those first 2 months is the highest spend at $36 million of any other of the years highlighted. So you just don't know, and we'll continue. I was hoping to have March data for this meeting, but it's not out there yet. This data is pulled directly from the United Health website, and it's just pure claims in real time.
So this is also where you can see this jump in claims from 2020 to 2021. I believe that was over an 8% increase. But then in 22, claims went down slightly. So claims decreased at 1.4%, and that's why we kept it without putting in the pharmacy rebates. We wanted to just show truly how our claims are trending, apples to apples. and compare that to what the actuary had actually projected. So the actuary projected a 2.2% increase in claims in claim year 2022, and we actually ended up having a slight decrease of 1.4%, which we were projecting a decrease. We were just hoping it was going to be more than 1.4%. Okay.
Okay, and moving on, this slide is very busy, but it actually represents the historical performance and projections from our actuary, assuming no increase in premiums whatsoever. This is what we would call a high-end, worst-case scenario snapshot of how our plan years will project in the event that we don't increase premiums. So our plan has maintained sufficient funding. As we mentioned, it's been a decade since we've increased premiums. We're in year 11. And the revenue has been sufficient to support the claims over all of those years until, the dreaded pandemic and calendar year 20, which is also plan year. Our plan year, as you know, runs from January to December. So Heather has talked about how the past 3 years have turned out. But if you look at the bottom, where the red box is, that is the gain or loss of the health plan year over year. And so the actuary predicted 29 million last year. And as you see, there was a loss to the plan, but we had funding sufficient to absorb it. And also the district had the benefit of the ESSER funds for plan years 2021, 22, and 23. If there are sufficient claims to support ESSER fund expenditures on the health plan, those have been just invaluable resources to support and maintain the funding of the plan. But as you all know, those are unfortunately temporary and will not continue. So the actuary predicts a $45 million loss next year for calendar year 2024, and even a more dire $58 million loss in 2025. Now, he bases his projections on factors like hospital trends, pharmaceutical trends, the legislation around pharmaceutical costs factor in, and he looks at the trend among those costs for like-sized employers, private and public, in the Southeast United States region. So he's looking at a broad trend with external factors considered. So as we referenced, he assumes some pretty dire numbers for 2024 and 2025. And so further drilling down through his projections, you can see a pictorial kind of rendering of what that looks like with the ending fund balance, the dreaded blue line that goes into negative territory, with the green line representing minimum fund balance. So the calendar year 2024 figure assumes a 7% increase in medical and 8.5% in prescription, and then 2025 assumes the 4.4% and 9% in prescription, resulting in a shortfall of $58 million between premium and plan expenses in 2025. Now, as the headline reads, that is the worst-case scenario we're projecting for the coming plan years.
And I just wanted to mention that green line, the minimum fund balance, since we are a self-funded plan, that's what we're required to maintain by the state regulatory. That's a state regulatory requirement, that we have to maintain 60 days of claims. So that is what that green line is. The blue line is what would happen with the fund balance. So if we were to do nothing, the gap between that yellowish line and the top of the claims, which is the blue represents the medical claims, the orange represents the pharmacy claims, and the little gray at the top is our administrative costs. So the difference between the top of the gray and that yellowish line is $58 million, but we'd also have to cover that shortfall between the ending fund balance and getting us back up to that minimum fund balance line. So it is actually even, more dire if we weren't to do anything, because we still need to comply with that minimum fund balance.
Okay, and then the next slide illustrates that again, which is kind of what Heather just said, how we would have to increase that revenue, worst case scenario, by 40 million plan year 2024, and then potentially another 18 million for 2025. And of course, we talked about the state's regulatory minimum fund balance of 60 days in claims in order to maintain our self-insured certification by the state of Florida, which we certainly like to do. So
And
that
so
we're
this-
not reaching into other things like,
Right.
yeah, other budgeted expenditures.
The proposal by the actuary is an increase of $58 million over the next 2 years.
So we are a 38,000 member health plan between our employees and our dependents. And so we're the largest employer in Palm Beach County. And so our own historical performance and the trends that we've consistently experienced over the past several years are credible projections as well. I mean, we are large enough to have performance that is statistically sound and actuarially sound as well. So consistently, we've done better than the actuaries' projections, with the exception of the pandemic years. Unfortunately, however, as we discussed, plan year 2022 did decrease 1.5 points, but not nearly as much as we'd hoped that it would. We were hoping that the pandemic was an anomaly that would kind of pass, and then we would be back to our calendar year 2019, our last normal year, so to speak, expenditures. It didn't happen. It wasn't as dire as the actuary projected, but nevertheless, we still have to look at the fact that our costs have increased since 2019 by about 6 or 7%. So going forward, we do anticipate increases. And if you look at these projections, though, the projected loss for this year is about 21 million, plan year 2023, with a projected loss of 26.5 next year, and then 31 million in 2025. If we do nothing, based on our own performance, our lower projected claims increase. There's still significant reduction, and if you look at the very bottom, the number of days of our 60-day requirement, gosh, it goes quickly from 121 days predicted at the end of this year down to 72 days next year, and then under that threshold in 2025. Even our best assumption if we do nothing, based on our own experience.
And so this is taking the average of the past 5 years in what are medical claims and pharmacy claims. So we break out the percentage of each and then apply that blended rate to represent the increases there. So instead of, if you recall, if you looked at the actuarial projection, the reduction in 2025 was 58 million. So based on our actual claims trend over the past 5 years, it would be $31 million loss versus the actuary of 58 million. So this is really a best case scenario compared to the actuary, which is a worst case scenario.
And to kind of put that into a colorful picture, this illustration for projections based on that district trend, we'd assume an increase of 22% for medical and about 4% for prescription drugs over the 24 and 25 plan years. You see, however, that without an increase in premiums, the ending fund balance, as we suggested, still takes a dip below the minimum fund required by the state. But it does look a little bit better than the actuary's projections. But somewhere in that $31 to $45 million range is our relatively dire prediction for 2024, just based on the reality of health insurance and healthcare trends. Do I have it? Did I advance? Okay. Okay, and so just to continue to expand on the district's trends, if we were to phase in approximately 29 million each year, we may not have to increase the plan as determined by the actuary. as again, our trend is looking backwards, his is looking forward with a lot of external factors. Ours is looking at our own internal trend. But it allows us, if we were to just phase in 29 million of an increase for calendar year, plan year 2024, it gives us time to monitor actual claims trend, as we did last year, collectively together, and also this year. And an increase to 2025 may or may not be necessary with this more conservative approach.
And you can see by looking at the calendar, or the calendar year 24 year, bringing it up to 29 million will get us to just about covering, the medical, pharmacy and administrative claims. And looking, keeping that 2% increase, it would be slightly, the premium would be slightly less than actual expenditures in 2025. So I think it was about a $2 million shortfall potentially in 2025. But this would help us to maintain our current ending fund balance, leave enough of a cushion that if claims actually trend higher than the 2% average, it gives us room that the district would still be in compliance with the state regulatory requirements of maintaining that minimum of that 60-day reserve without eating into that fund balance any further.
Okay, so this graph, when we compare our employee premium rates to those offered by other school districts, you can see by this illustration that we're very, very competitive, particularly as it relates to dependent coverage, with our representative colorful bars being the blue and kind of orange. You can look across all plans. When we get into the employee plus children, spouse, and family, we're just very, very competitive. Broward County, for example, offers all of its health plans at no cost to the individual employees, but it does not subsidize dependent premiums as published. I'm sure there's some implicit subsidy, but it just subsidizes dependents very little, if not at all. And as a result, only 11% of Broward's employees actually cover their dependents on their employer's health plan. So that chart is now illustrated just by a quick comparison of some of our competing school districts. The columns, the first columns that you see on the left, that is our employee monthly, that's your contributions, the employee monthly contributions for all three plans, for all four tiers of coverage. And then the next column represents those rates reduced by participation, active full participation in the health rewards. For full participation, an employee is able to enjoy a 50% reduction to their rates. And partial credit too during the year. I haven't illustrated partial, I've just illustrated the full participation. But you can see that our individual rates are competitive, but particularly our dependent coverage, particularly employee, plus children, spouse, and full family are very, very competitive as we look at other districts. So, just to recap, the health plan is facing a deficit ranging what we think for plan year 2024 from 31 million to 58 million for the next 2 years. And that's a huge range, but we've discussed it in detail as to how we're looking at our own experience as a realistic goal for funding for 2024. So our next steps to comply with state regulatory requirements, the 60-day so-called safe harbor, an increase in premiums is necessary for January 2024. The fiscal year 2024 budget is tight due to looming ESSER funding cliff, expansion of vouchers, and an increase in FRS, as we discussed, ranging from 7 million to 57 million, which is also a very wide gap of considerations. So just for considerations, phasing in 58 million increase over 2 years in order to monitor actual increase compared to actuarial projections, we would just look at plan year 2024 and phase in the $29 million of that full potential increase and monitor during this and next plan year, and then evaluate needs for plan year 2025 accordingly. We would potentially share those projected increases equally between the district and employees. So if we were just to look at that from an adjustment to just premiums across the board to employee rates, with no plan or benefit changes, half of that would be $14.5 million, which is about $30.82 per pay period, and that's based on 24 deductions, 26 pay periods, 24 deductions per year. It doesn't look at those remaining part-timers that you have in one of your agreements, but it does just give you a broad snapshot of what that might look like just across the board. You may want to talk with us. We may want to adjust existing rates to reflect actual cost experience, and then increase adjusted rates. And by that, I mean looking at the true cost ratios per tier. So, for example, our actuary calculated that for 2022, an individual represents the total individual premium, which for our low HMO, our most popular plan, is about $540 a month. For an employee covering just children, no adults, the cost ratio for that actual tier based on actual cost is about 1.64. So 1.64 times the 540 would represent the true cost ratio of employees covering children. For employees covering just one adult spouse or domestic partner, that cost ratio is 2.14. So that you can see that kids are just basically much cheaper than adults. And then for the full family rate, it was about 2.78. So we could create a model that sort of adjusts rates across the board to impact the true cost. We would still be competitive as compared to our peers if we were to look at a model like that. We could also look at our plans. We could eliminate the low option HMO to replace with a claim neutral hybrid high HMO plan. That would still require an increase of employee rates across the board. It would also drive more claims because the out-of-pocket costs are a little bit lower for the high HMO plan, so we would have to do some plan changes to offset those costs. But the plan would still likely be slightly richer than the low option HMO. And then if we were to eliminate the high option HMO, which is our cost driver, our notorious most costly plan, we could leave the low option HMO as is, and then there would be potentially a decrease in claims. But still there would need to be an increase in employee rates across the board because those rates for that plan are so heavily subsidized. So those are just some considerations at a 30,000-foot level to just throw out there as illustrations of what could happen.
And I did also want to mention and put on the table, because it has been brought up, that there have been plan design changes throughout the 10 years. So it wasn't that we didn't make any changes to our program, that those plan design changes did help to control costs. What we're going through now is that the majority of those plan design changes had no real financial impact to employees. For example, when the district decided to choose between using, instead of allowing employees to go to CVS and Walgreens, we then said, no, we're going to select CVS, and that resulted in a $5.9 million savings to the plan. So that was no additional cost to employees. It just resulted in an additional savings to the plan because the cost of prescriptions didn't go up. So what we're doing is we're looking at the different plan design changes to try to quantify which one of those plan design changes actually did result in additional financial impact to employees. Because we do recognize and appreciate the collaboration that we've had in those plan design changes. And, like I said, the majority of them, really, there was no financial impact to employees at all, other than just resulting savings within the plan. And that's why we kept those savings within the plan. We're able to, increase and bolster the fund balance, which has helped us now in this time to not do a knee-jerk reaction to increase premiums to cover that shortfall, but give us time to, especially in addition with the ability that we've been able to subsidize with the ESSER funds, be able to wait to have the claims start to settle so that when we have an increase, it's reflective of the true and accurate increase, not an inflated one.
And am I correct in saying there aren't really many additional plan changes that we can explore? Right?
Well, there always are. However, we've looked at our peers and their plan designs, and we're very much on point. Our plan designs are not overwhelmingly rich as compared to our peers. They're certainly competitive with our peers. They're not less rich than our peers, but our premiums are really the most heavily subsidized part of the whole model, and I think that's where we're best served to look for 2024 to ensure that we don't lose our healthy funding of our health plan.
And I think in prior years, early on, when we started noticing, we needed to do things to try to mitigate having to have increases, we worked collaboratively with you all, and prior to 2014, we did make some significant changes that actually did have cost impact. So that's where we changed deductibles, that's where we increased co-pays, that's where we implemented elimination of some of the plans. So you all worked very closely with us on, a number of years ago, actually making some choices that were plan designed that actually, I think, brought us to the point where we could keep things level for a while. And in more recent years, we have not made, cost impacts to employees.
I'm loud enough already. But, regarding the initial slide that showed the first 2 months of this year.
Yep.
Oh, there it is.
Okay.
What is the likelihood that February, because I'm looking all over, I was trying to look at, there are some that, say November to December of 2020, 17 to 19, then back down to 17. Is the district treating this as effectively just noise in a small sample?
Yes, so I'm not ready to come to you and say, because February was so much more than the previous February, I now agree that the actuary is right and our claims are going to increase, our medical claims are going to increase by 4%. 1 month is not enough to make that determination. So the point of this slide was, showing you that, the actuary, they are experts. This is all he does. This is part of what I do, but he was not right, when we looked at 22. And honestly, the actuary has wanted us to increase our premiums every year for the past 10 years. And as a district, we would look at our historical trends, and it didn't prove out. It wasn't substantiated by what we were actually seeing. And so the point of this is to say that the actuary is the expert. I need to tell you what the actuary is actually recommending that we do, but I do believe that is the worst case scenario. And so I want to go back to now that claims are starting to stabilize and to settle, I think we can go back and look at our past claim history. We do have enough in our fund balance that if the increase is more than 2%, which is what we're projecting, we have enough within the fund balance, within the health fund, to still allow the district to be in compliance with the state regulatory requirements. And then we can reassess again in 2025 if we need to increase. But I'm not ready to go ahead with we need a $60 million increase this year because we have been below the national trends prior to COVID. And now that our claims are starting to stabilize again, it's going to give us a chance to see, are we going to go back to being below the national trend in terms of claims? 1 month is not enough for me to say no.
Right, and if you look at our 2019 last normal plan year, there was a $21 million month in July, so you just, yeah, I mean, it's not, but I like to drop these every month and share it with you all, so you're seeing what we're seeing. I mean, if we saw a trend of 4 of those in a row, we might all think, oh, no, but I wouldn't expect that, and we'll just kind of monitor it as we go, which I think is a great strategy that you all have employed along with us, at least for my short tenure at the district, but also historically, and it's proven to be effective.
Yeah, I mean, part of that, I just kind of did the math of January and February, multiplying that, adding that together, dividing it by the months, then we'd look at, if it was a trend in that same direction, we'd be looking at a $216 million spend, which would be much less below of 2021 and 2022, obviously, but just to kind of reflect how early in the game we are.
Correct, right. And so that's why, let's go back and just look at we're taking the last 5 years, looking at the average claim increase of 2%, that's for the medical claims. The actuary is his estimate, he's projecting 4.4% in '25 in medical and 7% increase in medical in 2025. And we're saying, we think we're going to look at the average of the last 5 years, and we're projecting a 2% increase each year, which truly is the best case scenario. We are going to have an increase, but I don't believe that it's an average of 6% over the next 2 years. And then in prescription, and he's projecting a 9.1% increase in 2025, and in 2024, 8.5% increase. We're projecting 3.9%. I mean, he does have more information on different drugs new drugs that are coming out, generics that might be, new drugs that might be running into generics. So his estimates have a lot more right than what we're doing. But what we're doing is purely based on our historical trends. So for our prescription, we're looking at 3.9%. Because that's what it has been for the last 5 years. So that's why ours is, I believe, a best case scenario. His is a worst case. It's going to be somewhere in between. By phasing it in, it gives us a chance to see who's closer.
And I just want to make sure I heard you right earlier, was his presumptions did not include pharmacy rebates?
No, it does. It's just not in this table. And we kept them out of this table purposefully so that it's apples to apples comparisons. Wanted to see truly what is the true increase in the claims, because it's then going back to the actuary to say, how accurate was he based on his forecast? And if you add in the prescription rebates, it just adds in another level that it's not comparable. So the purpose of this was just truly based on claims, how are they trending? Because when we're forecasting, we forecast prescription rebates separately than we do our medical and prescription claims. It's not netted out. It's gross. And you can see that in this table here. The rebates are broken out as a separate line. You have premiums, and then you have your rebates, and then all other income.
See line number 3 up there. Yep. About 21 million, but it means that we're using a lot of brand name drugs. So it's helpful, but it's not necessarily ideal that we're using that many brand name drugs.
And we did have a pretty significant increase in our prescription spend, and that was a result of some certain new drugs coming on the market that were very expensive.
So just based on the monthly spreadsheets that we've been getting, which do include the prescription rebate, while the total there is roughly $37 million, 36, 37, there's 6.6 million off the top of all that right now. So in actuality, if it were a 2-month year, instead of being 36 and change, it would actually be about 30 and change, which is 15 a month.
But then we'd have to go back and look at how much the prescription rebates were in 2022.
Okay.
So that's why I just wanted to keep, for the purpose of this one, wanted to keep it just purely claims so that you could, because there could also be a timing issue when the prescription rebates come in. And so I wanted to just leave all of that out. And this was purely just to show what is our increase in trends, because we consider those prescription rebates separate when we're forecasting. And those are included in the forecast. So we still have the forecast for the rebates. We even forecast the rebates increasing over the next 2 years.
Okay. And again, the reason I ask, I guess, is because in terms of like deciding how to move forward when the time comes and looking at, and again, it's a 2-month sample size, so I get that. But with the rebates included, it's showing the average monthly claims right now at 12.8 million compared to 13.7 last year, compared to 14 the previous year, and then back to the same levels in 2020, 12.8. So with the rebates included, for the sake of seeing what we would need in the future, because that is a variable in what we need in the future, because that is a discount.
Right, but that is included in the forecast. The prescription rebates are included in the forecast. The purpose of this slide was looking at what the actuary had forecasted and where the district actually came in terms of claims, because I'm recommending that we don't go with the actuary. So I needed to explain why I'm not recommending that we go with the actuary who's recommending a $60 million, nearly $60 million increase in health premiums over the next 2 years. I'm recommending let's just go with half of that, because I believe that he's too high. So the purpose of this was to say I think that the actuary is conservative, overly conservative. He's always been overly conservative. Honestly, that is his job. I needed to justify why I'm recommending coming in with a lower amount. But the prescription rebates are included within our forecast, because you're correct, they do offset the cost of the claims. But we look at them gross. So we forecast the rebates as an income number, and then we forecast the medical and pharmacy claims as gross claims.
And so, help me real quick, maybe. On the monthly data that we'd been receiving, where it shows, like for 2023 through 2 months, that the prescription rebate is 6.6 million. That's over 2 months, so it's 3.3 per month on average.
Well, that's where it's timing too, as to when we receive the prescription rebates, as to why, another factor as to why we excluded them for just this table that's being used for illustrative purposes.
Yeah, because that likely represents some of the months, the prior months of 2022, because it arrived in January. We just plug them in as they come, as they arrive. It was high too, the last, it was like over 6 million, I think. But there was another rebate year, or rebate month in those prior years, but typically it's around 5.5, somewhere in that neighborhood.
But we do keep track of the pharmacy rebates. We even have them as a separate column within
your spreadsheet. Yeah. Yeah, we just wanted raw claims data that fit on the slide. So there it is. And, we look forward, I guess. I've chosen this career and love it. But I do look forward to kind of seeing every month what the claim spend is. And that's really the most real-time data that we do share with you, so you can keep right up to date with us. But it's certainly just raw claims, doesn't factor in a lot of other things.
Is there anything else we can clarify? I love this chart. I have to say, I created it. But I love this chart because it is one way to take all the information, have it on one slide, and just clearly depict, clearly see our claims, clearly see, how the revenue coming in covers it, and, our minimum fund balance for regulatory purposes, and what happens when you don't increase the premiums, and just how quickly the fund balance diminishes. Any clarification?
No, at least not for us. I think we look forward to seeing the month over months for the next couple months to get a better
And
picture.
that's why we've scheduled out the 5 months, just so we do have some time. But we didn't want to come, we wanted to come with you right now with what we think we need to do, so.
Understood.
And so at our next meeting, we will come back with, what would this actually look like to changes within the premium by these different tiers. So we'll have different proposals, one that's just the flat increase across all employees, and then, like Ms. Bolton had mentioned, tiering it based on the actual cost, where those with the employee plus spouse, the spouse actually costs more than the employee. We're spending more on the employee plus spouse than we are the employee plus children. So actually breaking out and the increase, instead of having a flat increase on everybody, tiering it more based on where are we seeing additional cost and prorating it more. So we will go through these different scenarios so that you can see what the impact to the actual premiums would look like.
Does anybody have any questions on these 4 options here? Okay.
No, thanks.
Well, thank you. Because I went back and looked, and so the first time we presented, we're most likely going to need an increase, was about April of last year. And so we waited, this whole year, hopeful that claims were going to decrease more than what they actually did. So we are definitely facing an increase for next year, and we look forward to working together, because we just want to make sure that the district complies. And just know that, what the district is facing from a budget perspective, whatever money we set aside and fund in terms of benefits is money that comes out of what we can give for raises.
That is certainly one way to look at it.
It's one pot of money. It's one pot of money that we have.
Can you humor me and run just the cost of increasing premiums for cops and principals? I'm kidding. I think it's you guys.
Like right now? Let me get my
Anti-authoritarian in me, I need to take it to you guys.
All right.
No, I mean, one thing I know Miami-Dade did, all jokes aside, Miami-Dade many years ago did go to a earnings-based premium system where it was based off of the annual earnings of a specific amount of premium increase. It won't shock you to hear the guy who's for SEIU say that we would explore something like that, though obviously others in the room might not be so amenable to that.
We did look at that. We are aware that Miami-Dade does do something differently. The problem is that you don't get much benefit from that. When you actually look at the number of employees we have and how the income, the spread of the income, you're not going to get much benefit from increasing it on those that make a certain dollar more. It's not going to be enough to truly make up the shortfall that we have at this point.
Any other questions or discussion? All right, well, other topics that we wanted to at least cover, make sure you're aware. We talked about this last year during negotiations, the dependent verification process. So just want to give you a heads up that that process has begun. It ends May 8th. So, we really just ask that you urge members to act on it. Make sure they pay attention to the email. Some people might get tons of emails and might just delete, but they have dependents, they have to verify them by May 8th. So, and then you can see there our next sessions, we've got one scheduled for each month through August, so.
Yep, and we have about just under 20% of our dependents verified. About 17% of our employees have completed that who have dependents, but we still have a lot to go, so.
And it's a fairly simple process. I mean, I did it in probably, 20 minutes. It's really just get the documents and put it in, a birth certificate, marriage certificate, things like that. It really isn't difficult. They make it very easy. You could upload a picture from your phone. It was very simple.
What is the sequence of events or communications that would go to an employee that does not meet that deadline and comply in time?
We're still discussing that with our consultant around regulatory issues. You know, we updated our dependent eligibility policy with language that supports retro terminations under the Affordable Care Act. You know, language that says, you know, you can't intentionally cover an ineligible dependent, and we consider ineligible dependents intentionally, you know, misrepresented, and that language is provided under the Affordable Care Act. So we provided an amnesty period through open enrollment where we communicated, you know, now's the time, take your ineligible, review your dependents and take anyone that doesn't meet the criteria off the plan. So when we get the data and we look at claims paid or premiums paid on behalf of ineligibles, we will have to make the decision as to how to address that, and can we go back to the policy update, which was March 29th, or back to the first of the year after our dependent eligibility, or excuse me, after our amnesty period. So we're still working with our regulatory folks, our compliance attorneys from our consultants' side of things to determine what's appropriate there. I will say that out of the 20%, we're not seeing a huge fallout there. You know, there were 3 children who turned 26 this month who kind of showed as ineligible, but they're fine because they have till the end of the month to get them off the plan. There are a few others, but the number's not significant so far.
And you said the plans collectively currently carry 38,000 individuals?
Roughly 38,000.
Is there a projected, like, drop-off based on assumed ineligible, like 1%, 2%?
So 4 to 6% is the typical number of ineligible dependents that are discontinued after this type of exercise. We really don't want to see that because we hope that we've communicated sufficiently.
Yeah, we expect, since we gave notification, especially during the online enrollment period, there was actually a pop-up that came up that said, make sure that you double check that your dependents are eligible. And we provided even a link to how you determine eligibility. So we do believe that most of that was addressed, most of the non-compliance was addressed during open enrollment period. So that's why we expect ours to be less than what the average is.
We hope. And it was, you know, communicated in a bulletin, which is a formal communication document that hopefully people.
In an email.
Yep, and emails and through, you know.
Multiple emails.
Yeah, scrolling
bulletin.
banners during open.
Well, I mean, when an email went out to all district employees, and then if you have a dependent, you got emails to how to register, how to, you know, do everything, so.
Yes.
Thank you.
All right. Anything else before we wrap it up? All right, well, I'd like to thank Heather and Nancy for putting this information together, and thank you all for coming here today. I look forward to seeing you on May 23rd with an update, and if we do get any claims updates before that, we'll be sure to send them out. All right? Thanks, everybody.